and thank you for joining us for another episode of Hope for Healthcare with Dr. Katie Cole in partnership with ICD Healthcare Network. Dr. Katie Cole is a holistic physician, organizational well-being consultant, and change agent, working with industry leaders in proven strategies to heal our national healthcare system and our culture of medicine. Stay tuned to hear today's speaker.
All right, well, welcome everyone to Hope for Healthcare. This is a podcast in which we interview expert leaders around the country on best practices for healing our national healthcare system and our culture of medicine. I want to extend a very warm welcome today to my esteemed colleague, Dr. Sisi Hu. Dr. Hu is a co-founder and chief well-being economist at Adelan, a women-led, mission-oriented company focused on using machine learning or AI to predict and prevent clinician burnout and turnover. She is also a research fellow at the Center for Labor and a Just Economy at Harvard Law School and research economist at the National Bureau of Economic Research, where she focuses her work on clinician burnout. Her expertise is in risk science, where her work has received media attention from around the world, including the World Economic Forum, Sky News, the UN, and many other global organizations. Well, welcome. And I forgot to ask what you want me to call you during the interview, CeCe or Dr. Hu, but welcome to Hope for Healthcare.
Thank you so much, Katie. CeCe is fine.
Okay, great.
Yeah.
Well, thank you for being willing to come on the podcast today. I know we have a lot of exciting things to talk about, and I'm really curious. Initially, I always like to know what your story is in terms of how you became interested in studying and researching clinician burnout in healthcare.
Mm-hmm. Yeah, thank you so much, Katie, first of all, for having me here. It's an honor to be here and to be with you and with your audience. Yes, my name's CeCe. You may have guessed that from my slight British accent, I grew up in the UK. So before coming to the US, I did a lot of research in basically risk science, and specifically in the context of climate change. I was really working on how to understand the climate risks and develop models to come up with sort of interventions or sort of adaptation ways to solve the problem. So I came to the US about 6 years ago during the last year of my PhD. I was finishing my PhD back home at Oxford in the UK. And then I came here for my postdoc and started my postdoc at Harvard around looking at really labor issues. I kind of changed gear a little bit. And during COVID, we very luckily received a National Science Foundation funded grant looking at COVID impact on healthcare workers. That's when I really started sort of getting into this space and getting really interested and passionate about it, because I talked to more than 100 health systems across the country, about 150 healthcare leaders and clinicians by now, and basically I felt very emotionally connected with the people that I spoke with, because I literally had physicians and nurses break down in front of me, and that was really heartbreaking for me to see. And I started thinking, oh my gosh, if we had a health system, like a health care industry that doesn't have nurses and doctors and other clinical staff, we would really be struggling as patients, right? So I kind of really decided, I thought, yeah, so they're burning out and they're really struggling and they're leaving the healthcare industry. This is not an okay thing. So for me, it was more like a personal calling. I thought, okay, if I'm able to contribute on this issue, I would just love to work on this, and got really passionate about it. Yeah. Thank you.
Thank you for your passion as a scientist and coming in to help us figure out how we can move forward in a healthier manner. So I appreciate that.
Yeah, thank you for your kind words. And I think during my research, I really found something quite extraordinary. Like as an economist, I am used to using economics to do different things. But I think in medicine, at least in the interviews I did, I found that economics for our clinicians is a very traumatizing phenomena. So you're constantly told you need to see more patients, you need to generate more RVU, you need to be more productive. But it's not economics shouldn't be this way. And really, I think economics, if it's done the right way, it can be used by our clinicians as an empowerment tool. And because economics, you can actually show the true cost of burnout, right? You can prove to people that, hey, this is a really problematic issue, and you can also use it to calculate the returns on investment of doing something about it. So economics really should be a tool that is used by our clinicians or leaders to really fight for their own well-being, because this is something that is really important. And it's really important to demonstrate the sort of business case in investing in clinician well-being. So that's what I found during my research, and I really want to. And I realized this whole piece is missing in academia right now. So the economics of the clinician well-being. So I really want to, work with our health system partners and basically to create a new field of the economics of well-being economics. And it's kind of built on the foundations of like compassion economics, and there are other sort of emerging fields that really are starting to tackle this issue. But I really want to do some good around there on that topic.
Well, great. And I'm really curious. Our audience is definitely going to want to know more about the platform that you built with your business partner and what you're actually doing with healthcare systems nationwide currently.
Absolutely. So before we dive into the platform, I do want to tell a little story of how we actually started. So when I was doing all this research during COVID, actually one of my best friends, whom I've known for years, Tiffany, she basically is someone I met at Harvard back in the days. And she came to me and she was independently working on a project on clinician well-being. And she is let me say, like, she's somebody who acts on things, and she's somebody who is really an inspirational source, and she's a little crazy, to be honest, but crazy in a very, very good way.
Okay. Just remember, I'm a psychiatrist, so.
But I think it's just that she's just full of energy and she wants to make a difference. So she kind of reached out to me and she was like, well, you're doing research on, clinician burnout and well-being. I'm working on something similar. You have this kind of research background. I have this sort of operational sort of implementation background. We should do something about this. She's very passionate. And she was like, do you want to develop something, like a tool or to help our health system leaders to really tackle this? And I was like, oh, well, I kind of, have a relatively stable and established career in research. Why would I jump out? And I told her, like, if you jump, I will jump. I was kind of jokingly, but I did not expect that she would jump, actually. So she actually jumped, and she declined 6 job offers after she finished grad school. And she basically said, look, I'm doing it now. Are you coming or not? So I was like, shoot, okay, I'm coming. So we co-founded the company together, Atlan. And our company mission is to help our healthcare workers, and specifically to support health systems to basically measure and benchmark and really mitigate like clinician burnout and turnover using data and data-driven technologies. So that's kind of where we come from. In terms of the platform itself, it's really used by health systems at multiple levels. So C-suite leaders as well as local leaders, they use our platform basically to do hotspotting of risk, so basically identify the hotspots and units that are really burning and needing help. They use our system to basically budget. So essentially, we calculate in the background what are the costs of turnover, what are the costs of burnout, and how much you should be budgeting. And then we also help our system partners to track interventions and document basically interventions, so that in the background with time, whether your interventions are working or not. So like in essence, that is what the platform is designed to do.
Okay. Well, and can you tell us a little bit about how you came to how you created your model over time and the interview process with hospitals and healthcare leaders nationwide, and maybe some lessons that you learned ahead of time before building the model?
Yeah, absolutely. So we built the model from using a very scientific approach. We basically, as a team of scientists, we read, I think it's probably 3,000 or 4,000, like thousands of papers, scientific papers that basically looked into what are the predictors of clinician burnout and turnover. So we drew those predictors out in the literature, and then basically we marry them with raw data that health systems already have. So those are EHR data and HRIS data and any survey data they already have. And then we basically feature engineer the raw data into these predictors, and then build an ensemble of machine learning models that basically process the data and then generate insights that are actionable. So those insights are basically, hotspots at unit, but also not just the sort of like burnout and turnover risk at the individual level, but also why, like the reasons as to why people are struggling. So with that information, everything is aggregated up to the unit level. So the unit, like clinical leaders, can actually act on this information and develop really sort of risk driver targeted interventions that is very sort of can be much more effective, right?
Mm-hmm.
And then we basically built another set of economics model to track the effect size and also the ROI of different interventions over time. So that's like the process that we sort of went, and we worked very closely developing all these models with our health system partners. So they would tell us, hey, this risk factor does not make sense. You should not, because it's not actionable. What we found, a lot of the predictors are also are things that would improve the model accuracy, but they wouldn't actually necessarily be easy to act on.
Can you give us an example of that?
I'm thinking, let's say like department name, right? Like, so basically the hypothesis, like different specialties have different risk drivers, which is true, but it's the variable in itself is a department name. Pause. I don't know if we need to go into the detail. Do you think, I mean, I can explain it to you. Like basically, let's say department name would actually be a big predictor, and the hypothesis, the intuition behind it is because, let's say emergency care, it's just usually it's a very special, department that has very high risk of burnout and turnover. That would come up, but then what would you act on it? Like, what would you act on a department name? It's not things like, weekend hours or like pajama time where you can actually go deeper and be, say, hey, this is a work distribution issue maybe, and then we can do interventions. But in our predictors, we put in a lot of variables or predictors that actually matter for the models, but they don't necessarily matter. So, but it's actually really that, I think that's the hard part about the science. The science, you can put in much, a lot of data, but how do you actually translate the model results into something that is actionable? And that's what we spent a lot of time doing. For every risk factor, we develop a set of intervention strategies that are actionable. So everything we surface is you can do something about it. That's the philosophy behind the design of the platform.
And one of the things that we had talked about earlier is that your model is different, and then it's not just retrospective, because that's the feedback that you got from a lot of healthcare leadership around the concept of wanting something that can actually look into the future and give them a sense of what's happening in the next year or so.
Mm-hmm. Yes, that's correct. So we hear a lot from our health partners that basically right now they are relying on surveys, which are great. They want us to be actually a complement to the surveys, because they are they usually examine, identify some risk areas or like problem areas using a survey, but surveys cannot really predict ahead of time. So the healthcare partners ask us, hey, can you look at the survey data for us and also look at other data sources that we have, so we can actually get ahead of the game. So we really come in as a complement to surveys where we help our partners to look ahead, like 6 to 18 months, into the future, predict. But because typically surveys have quite low response rates. So nationally it's around 30%. So if you are really, developing, that's one of the pain points actually that our partners tell us, hey, I have bad survey response rate. Can you help us find other data sources that can cover the 70% of the people who are not actually responding, but we know that they are really more at risk of being disengaged and stuff like that. So we developed a set of models that actually take data you already have and covers everyone. So that's how we are really quite different, I guess, in a complementary approach. But we also, within the platform itself, we have developed all these different models, right, to try and basically calculate the ROI and budget and for interventions. And those are things that surveys are not really designed to do yet at this stage. So that's how we are kind of really work together with surveys, and we are slightly different.
Got it. Well, I think that's a really important point to talk about because, there are a lot, every hospital and healthcare system is doing their own thing when it comes to where they are even on the continuum of looking at well-being for employees, if they've even employed a survey. But I really like what you said earlier about that your model uses whatever the healthcare system has already done, and including all of the HR data and taking data points from the electronic medical record. So CeCe, earlier in our discussion, we also talked about the fact that you and your partner, Tiffany, are in the process of designing a national consortium. Can you tell us a little bit more about what that looks like and give us a sense of when that's going to launch?
Absolutely. Thank you. So when we did this research, we find actually, what is really missing is the intervention piece. What is the real-time evidence on whether things are working or not? In the literature, there are some good papers, very, very good papers, but which all kind of happen in an experiment setting, right? So you would say, this is the intervention pilot that we would do, and we would observe the before and after. But that's really challenging because, how our healthcare partners and the people that we've interviewed, they're like, that doesn't really necessarily apply to me. Like, there's no guidance around how I can implement these. How did you come to this particular outcome, right? Like in the papers. And there is literally very little amount of actual localized level type of documentation or literature around interventions. So that was the big challenge that we wanted to really address through this national consortium on intervention evidence. And what we want to do is essentially within our tool, within our platform, local leaders or the people who are really responsible for implementing the interventions, they actually have a space to document what they're doing and who is involved, what budget falls under. So we have all that data, right? We will have all that data. And what we want to do is with that data, you actually have a timestamp of when the intervention was launched, who were involved, and what are the outcomes the metrics that we're tracking. So over time, we will be able to provide that real-time evidence of what actually happened after a particular intervention is launched. And we want to create that database at multiple settings across different, units, so that people can start sharing what is, are the actual implementation steps in addition to the evidence on the interventions. What is working, what's not working, who was the actual, were the stakeholders that made things happen. And actually, if you imagine, if you have one system and you have evidence on, other unit have, successfully got some evidence in a particular metric and they reached out to this particular person, I should be doing that maybe. So it really helps break down that barrier, like that problem where people don't know, who to talk to in order to get resources, right? So we're really trying to create that system, and also then create benchmarks around, standards, and so you can sort of see how well you can improve in the future and that kind of stuff.
Okay, yeah, that makes sense. Oh, that's great. And I think, we all agree that, healthcare is definitely so siloed, and that's been sort of part of the well-being movement, is that we really want to bring all the information together and try to break down those silos, because that's part of growing, is sharing what we've learned along the way. And every healthcare system and and location is just so unique within their own, burnout factors, turnover, what's driving their costs as well. So I like that you are building the national consortium, and I'll look forward to seeing how that goes, and we'll probably check back in another year to see how things are going along with that project. Yeah,
that would be great. We're excited.
Well, CeCe, you've really done a great deep dive, I think, into your process with Tiffany and how you guys came up with your model. And is there anything else that you want to share with the audience? Any last with them?
Yes, actually. So last thing that I would love to share is that we are launching a new version of our platform in October with 8 health system partners across the country. They're all kind of well-being leaders right now. And the great things about why I'm excited about the platform is because it's now got all the features that I really wanted to push into the platform. And that is not just about a data dashboard. It's actually about action. How do we use technology to empower action planning at every step of the way in the well-being journey for health system well-being champions and leaders.
Mm-hmm. Well, great. And if I'm a healthcare leader, whether I'm in the C-suite, CWO, chief nursing officer, and I'm listening today, what is the best way for me to get started and to reach out to you for a consultation?
Yes, that would be great. So if you are happy to, please reach out to me via email or LinkedIn. So my email is cc@atlantech.com. And I'm very easily findable on LinkedIn. It's CeCe, SISI, She Hu, XIHU. And if you search Atlant, it will come up.
Oh, wonderful. And for all of those of you listening today, I will have all this information on CeCe's bio page on my website, as well as LinkedIn, and we'll have links to the article too, so that goes more into detail describing her model that she developed with Tiffany. So, well, thank you so much for being here today, CeCe. I really appreciate your time, and thank you for your dedication and commitment to healthcare well-being.
Thank you, Katie, so much for having me. It's an honor to be here. I've really enjoyed the conversation.
Me too. Thank you so much. And everyone, I hope that you have a great rest of your week, and I'll see you soon.